Welcome back to part 2 of Palpitations in Long COVID. I'm Dr. Tim Robinson, formerly a family doctor for 30 years, a GP, now working in Long COVID Services for 5 years. I'm posting on all the usual podcast channels as well as YouTube, and I hope you find them helpful. And if you do, obviously click subscribe. I want to get this message, all these messages, out to as many of you long COVID sufferers as possible. My usual disclaimer, of course, is, basically any advice or treatment that I mention should only be considered after you've discussed them with your own doctor. So here we are, part 2. In part 1, I talked about patients, who are experiencing palpitations and, basically what are patients actually saying to us in their clinics? What other associated symptoms do they have with their palpitations? I talked about the process that you go through with regard to getting a diagnosis, seeing the doctor, and then I also talked about the causes. Now here in part 2, I'll talk about how we're going to tackle them. So, just to recap, like I said, the symptoms. What are patients actually telling us? They're basically coming and saying to us, I'm experiencing this thudding, this thumping heartbeat in my chest. It's either regular or irregular. It's just a single one-off or a whole sort of run of them, multiple palpitations. What do? Basically, anything new, any new symptom, what do? You go to the GP, don't you? So, the GP will then sort of take your history and examination and investigate as relevant. And the reason for this is obviously we need to get a diagnosis. The GP, of course, will also be thinking about the red flags, those more worrying symptoms that perhaps suggest a condition, a more concerning condition that is, presenting with those palpitations. Having been through all that process, then it's a case of, having come to a diagnosis, and the GP will then be able to advise as well as treat accordingly. So, what are the treatments for palpitations? Well, the first line treatment is with a drug called bisoprolol. This is one of a group of drugs. The group is the beta blockers. You may have heard of the beta blockers. So the first beta blocker that came out of the beta blocker stable was propranolol. That was about like half a century ago. Which was excellent at controlling blood pressure, controlling heart rate as well. And it's used for other things like migraine prevention. But it is not entirely what we call cardioselective. So it has its effects in other systems around the body. Because of that, they tweaked it a little bit, and from bisoprolol they then found the next one along the line, which was atenolol. A number of other ones as well, but atenolol was the common one that we used for many years. They then tweaked atenolol, if you like, or found another one that was even more cardioselective, called bisoprolol, and that's the one we use mostly these days. The reason why it had to be tweaked and we wanted it more and more cardioselective is that propranolol, and to a lesser extent atenolol, basically caused constriction in the lungs in patients who were asthmatic, so bronchoconstriction, wheeziness. So it tended to trigger asthma attacks in patients with existing underlying asthma, which isn't that good to They didn't thank us for that. It's not what you want. And so hence the development of bisoprolol. However, nowadays, it's stuck in the rule book. So anyone that we're considering treatment with bisoprolol will usually ask whether you have asthma, yes or no. And there are some patients who have slightly more brittle asthma that's more temperamental and fragile and difficult to treat. Those patients we probably wouldn't necessarily treat with a beta blocker, even bisoprolol. We'd be looking for an alternative. But for patients whose asthma is well controlled, and it's quite mild, then probably bisoprolol is safe. But you want to start it at the lowest dose possible, so 1.25 milligrams, and then you can increase the dose and titrate it up according to the need. 1.25 milligrams might be sufficient to control those symptoms, control your palpitations. However, doubling it to 2.5 is certainly acceptable, still a very low dose. But it all comes down to how well you tolerate it, whether there are any side effects, and how effective it is. Beta blockers as a whole not only have that tendency to trigger asthma, but the commoner side effects are basically heavy legs and fatigue. So, okay, you're thinking to yourselves, that's not good. Of course, if you've got long COVID, you've probably got fatigue anyway, and you may well have heavy limbs associated with that fatigue. So actually, well, you're getting fatigue for two reasons. One is the bisoprolol, and the other is for your long COVID fatigue. Probably a reason why you probably wouldn't want to have that beta blocker, that bisoprolol, as your treatment for your palpitations. In that situation, you probably want to go to second line. We'll come on to that. The other, not uncommon, but you see it from time to time, patients who are put on a beta blocker do complain of vivid dreams. And if they are particularly troublesome, wake up in the morning completely exhausted because you've had weird, crazy dreams, and you wake up like, oh, thank goodness I'm awake now. You probably, again, want to have an alternative to bisoprolol. So that's bisoprolol. And actually, it is effective for the vast majority of patients with long COVID palpitations. And GPs will willingly prescribe this and are very familiar with prescribing bisoprolol. It is tried and tested. It's from, like I said, that group of beta blockers. Beta blockers have been around for 50-something years, and so we're very comfortable with prescribing it. You don't need referral onto a specialist for that. However, like I said, if bisoprolol is not doing the job, then, or you can't tolerate it, or it's contraindicated, then on to second line. And there's an excellent newer drug called ivabradine, which is what's known as a SAN inhibitor. SAN stands for sinoatrial node inhibitor. So it basically, it dampens down the nerve impulses in that node, which is located in the heart. And so therefore it dampens them down, therefore it controls them, therefore there's going to be less in the way of palpitations. It's great because not only does it control the palpitations, but also it doesn't have an effect on blood pressure. And beta blockers, bisoprolol being a beta blocker, not only does it control the rate, but also reduces blood pressure. So actually, ivabradine wins for that, especially if someone who has reduced blood pressure as part of their long COVID, not only have they got palpitations, they might have dysautonomia, dysfunction of the autonomic nervous system as well, bringing about low blood pressure. So therefore, ivabradine is great for those patients who have a bit of both of those things. It is a second-line drug, and so it is initiated by the cardiologists. And then once the patient the cardiologist has found the correct dose, then the cardiologist usually writes to the GP and saying, please, I'm now control the palpitations for your patient. Please, could you take over the prescribing of this drug, which is safe? And more often than not, GPs will take over that prescribing, which is a lovely understanding between GPs and hospital consultants, cardiologists. I've talked about dysfunctional autonomic nervous system, which can go hand in hand with palpitations in long COVID. And so there are, like I said, there are other associated elements to dysautonomia. And one of them is blood pressure, reduction of blood pressure. And there are a couple of drugs that can be added in. So midodrine is one, and there's fludrocortisone. These are other drugs in patients with palpitations, long COVID palpitations. They may need those additional drugs if they have those other elements of their long COVID palpitations. There's non-pharmacological. I've talked about pharmacological, just the medicines, the drugs, but what about non-pharmacological, which should certainly be considered. So there's compression hosiery, so flight socks, or long sort of leggings above knee, below knee, above knee, sort of compression stockings, which push blood back up into the circulation. Some people, incidentally, find those sort of tight stockings really uncomfortable. And a lot of patients are using those exercise leggings, but a lower size than normal, a smaller size than normal, to achieve the same thing, and that is to push fluid from the legs up into the core, up into the body. And if you can do that, it means that there's improved return of blood to the heart, which in turn it turns off that reflex to increase the heart rate in order to sustain the circulation. So basically, by using that compression hosiery, flight socks, or sports leggings, that pushes the fluids back up into the circulation, which is a way of combating those palpitations. The other ways to combat it is to actually increase the circulating volume, and the way we achieve that is to take an extra salt in the diet. So a teaspoon of salt, that gives you 6 grams of salt added to your food or stirred into some orange squash or whatever and drunk down, is a way of expanding the circulating volume. Another way, of course, is to take more fluids, so 2 to 3 litres a day of clear fluids, or squash or what have you, maybe with that salt added, will go to expand that circulating volume, and hence improved blood return to the heart, and hence less reflex tachycardia, palpitations. The other thing to note is that there are things in our diet and things that we drink that can increase the heart rate. So the classic, of course, is caffeine. So caffeine is in coffee, of course, as well as tea, as well as chocolate, as well as those energy drinks, those Lucozade sort of endurance drinks. So if you have excessive caffeine intake, then that will stimulate the heart. Caffeine is an amphetamine, and it's a cardiac stimulant. So it makes perfect sense. You've got to try and reduce your caffeine intake. So again, certainly in general practice, I remember a couple of patients a year on average, would come saying, I've got palpitations. I don't know why I've got palpitations. I'm worried about it. I'm a fit, athletic type, and I've for some reason I can feel my heart now. And then I ask, why? How many cups of coffee do you drink? Oh, I drink 12 cups of coffee. I need to stay alert because my job is really intense and high demand. I've got to be on it, so I need 12 cups of coffee a day. Well, that's the reason. So I say, look, okay, bin the coffee, no more coffee for 3 weeks, and come and see me again. They come back, big smile on their face, palpitations gone. I said, okay, well done, fantastic. Basically, you can go back on coffee now, but 2 or 3 cups, maybe 4 cups a day, that's probably your limit. So see how it goes. Obviously, if palpitations came back again, they're really sensitive and they'd have 1 cup of coffee a day or what have you. You get the drift. So basically, excessive caffeine in coffee and those energy drinks, etc., will bring about palpitations. I've sort of focused on the long COVID palpitations. Remember the other palpitations, the irregular ones, those the single one-off palpitations or the runs of irregular palpitations. So the singular ones, happening every once in a while, quite normal in the normal population, obviously don't need treatment. For runs of irregular palpitations, so remembering that diagnosis, atrial fibrillation, that's obviously more concerning because, like I said, atrial fibrillation can lead to blood clot forming in the heart, which can go to the brain, and that can cause a stroke. Obviously, we want to avoid that at all costs. So treatment for that is bisoprolol. But again, obviously, your doctor will either treat you or you will be referred on to a cardiologist. But again, it's good old bisoprolol. That is our rate-limiting drug that we use nowadays. We used to use digoxin, but that's fallen out of favor because of side effects. Along with the rate-limiting, we ought to prevent this tendency for clot formation, and so blood thinners, so aspirin, antiplatelet, as well as a DOAC, so direct oral anticoagulant drug, such as apixaban, is used in this situation with atrial fibrillation. So there we are. That's it. That wraps it up. So basically, let's just quickly summarize. Any new condition, you want to go to a doctor. So in this situation, in our circumstance, in this podcast, it's basically palpitations. Take them to your doctor. New problem, off to the doctor. We don't want to be COVID blind. Basically, your palpitations may be due to, something completely unrelated to your COVID and your long COVID. So remember, don't be COVID blind. Take your palpitations, your symptom to the doctor, because the doctor's going to make a diagnosis. I talked about the causes and the multiple causes that there are in long COVID. We're aware of this, the excessive inflammation, the dysregulated immune system, all those causes. And then I covered the drugs, the medications, how we're going to tackle them. That's how we do it. However, let's not look at this in isolation. Think about the overall management of long COVID. And what have we got to consider? We've got to consider fatigue management. Remember the 3 Ps, the planning, the prioritizing, the pacing. We've got to avoid boom and bust, crash. We've got to avoid post-exertional malaise by making sure that we live the 3P life, and that is the planning, prioritizing, and pacing. We want to do some gentle reconditioning with our muscles. So yoga's good for that, for example. We've got to get the conditions, the muscles and the limbs and the ligaments working again. Yoga's good for all sorts of reasons. Yoga's good for, controlling your breathing. And controlled breathing is actually very stimulates the vagus nerve, and that slows the heart rate also. Again, slowed heart rate, less palpitations. Good result. Also, yoga, whilst we're on yoga, is also good at focusing on the now. Again, not sort of looking back and with regrets and doom and gloom, and looking forward with anxiety, worries, concerns. No, focus on the now. Okay, that's really important. So yoga is good for that as well. Yoga is good for lots of things, but focusing on the now. Also think of mindfulness. Again, mindfulness and yoga, backed up by lots of evidence-based published journal publications on how effective it is for reducing blood pressure, reducing stress, etc., etc. It's all there. And then there's this sort of other measures, of course, always there in the background, but on a daily basis, make sure we eat sensibly, that mixed balanced diet, the Mediterranean diet, to provide all those goodies, the vitamins and the building blocks for cellular recovery. And also support the gut microbiota, of course, never forget the old friendly bacteria. But also sleep, remember, sleep hygiene, good, plan sleep, think about blackouts, eye visors and no screen time, an hour before going to sleep, because that's quite arousing and sort of gets you sort of G'd up. And natural healing. But remember, natural healing takes time. So it all takes time. It's long COVID for a reason. It's long. So there we are. I hope you found that helpful. That update on palpitations, long COVID. And, like I said, my usual disclaimer though, any advice or treatment that I've mentioned, please discuss with your doctor. Remember, safety first. So if this has been helpful, subscribe. Let's get the message out there to as many of you long COVID sufferers, anyone that has long COVID, spread the word, share these podcasts, etc. I just want to help as many people as possible. Thanks for your feedback to the channels. Basically, apologies in advance. I can't reply to basically your comments and your stories and your queries, because I just don't have the time. I wish I did, but I just don't have the time. So apologies, but keep them coming, because I do find them helpful with future postings. Really, really helpful. So keep them coming. So in the meantime, there we are. Thank you very much indeed for listening, and I wish you well in your long COVID recovery. So all the very best. Cheerio now.